I want to extend my welcome to all of you who are here in Edmonton, anyone else who may be elsewhere in the province. Carol introduced me. I'm Karine Morin. I'm the Executive Director of Platforms, but also have the responsibility for ethics innovations at Alberta Innovates Health Solutions, and that is where the Health Research Ethics Board of Alberta, it's a mouthful for even me, where HREBA is housed. And we're really delighted that this activity, this session today is being, was co-organized with the John Dosseter Centre for Health Ethics. So I thank the interim director, Paul Bird, but also Carol for welcoming us onto campus and making it possible for us to be having this session that is viewed across the province. So we hope this is a first, but not the last. Thank you very much for your assistance. I want to say just a quick word about HREBA, the Health Research Ethics Board of Alberta. I still consider it to be a newbie. It was established essentially just 2 years ago and came together when 3 different research ethics boards were joined to become one. So there is a committee that reviews cancer studies, a committee that reviews clinical trial studies that are conducted by principal investigators that are not university affiliated, and then a community health committee that looks at other studies that are conducted by PIs in the communities. So HREBA is one of 3 HIA, Health Information Act designated REBs in the province, and along with the University of Calgary's CHREB and the University of Alberta HREB. Don't you love those acronyms? Can you get more of them in your presentation than I have in my intro remarks? But those 3 research ethics boards in the province are involved in a harmonization initiative, and we're hoping to make Alberta a place where research ethics is conducted as efficiently and smoothly for research that goes on in the province. So I won't say much more about HREBA, but I hope you'll come to know us in one way or another. I was really delighted that we could try and have 2 sessions this week that would touch on rehab, because it's not the foremost topic that we think about in research ethics or perhaps even in clinical ethics. But to have 2 sessions devoted to these issues, I think will just shed some light on how complex issues can be in rehabilitation. So today we're looking a little bit at looking at this from a research perspective. And I can't think of a better person to speak of these issues than Linda Woodhouse. She provided a modest bio, and I'll refer to these, but an accomplished physiotherapist, so has the clinical hat on, PhD, and therefore well-versed in research. She's currently the Associate Professor and David McGee Endowed Chair for Musculoskeletal Research, Faculty of Rehab here at the U of A. She has the research ethics credentials as she has served on the research ethics boards in Sunnybrook Health Sciences Center. She served as a scientific director for one of the SCNs, Strategic Clinical Networks. That was the, let me get my lines right, Bone and Joint Health Strategic Clinical Network, and is still affiliated with the McCaig Institute for Bone and Joint Health in Calgary. She is also the president of the Canadian Physiotherapy Association, so clinician, researcher, policymaker, credentials in research ethics. Delighted that you'll be talking to us about ethics and challenges of collecting, using healthcare data in rehab. On to you.
Thanks, Karen. And I wanted to say thank you to AIHS and to AHS and how many other acronyms I can get in there, just for bringing sort of disparate groups together and tackling really challenging areas. My game plan was to spend about the first 20 minutes or so talking to you a little bit. I hope this will be practical application of ethics, and then open the floor with Karine and you to have a conversation about what challenges you face. And I'll also say that now that Karen's told you all the different places I'm from, none of them will claim that I'm speaking on their behalf. So I'm usually fairly provocative, trying to push the envelope, challenge us to go into different areas. So please don't hold any of the organizations that have an affiliation with me or that I have an affiliation with responsible. I hope to be a little bit provocative as we go through, but helpful and challenging of what we have to look at as a group together. Really, the challenges, I think, are and I'll just take a couple slides to talk about what's the sustainability of our healthcare system. Do we in Canada truly have a national healthcare strategy that's very well organized and a great healthcare system or not? And if not, what are the challenges we face and how do they impact what we're going to talk about today in terms of data? Can we develop an integrated data system? Eric Meslin, for those of you that were there, a bioethicist, was talking this morning about how do you integrate public and private sector? What are the barriers? What are the perceived barriers that really aren't there but we think are there? And so we hide behind those challenges instead of going forward together. What are the value and challenges of looking at secondary data use? What is secondary data use really all about? Everybody's talking about it. It's a big buzzword, innovation, secondary data use. But what does that really mean? And how do you, and I'll give you an example from my experiences with bone and joint health, how do you use data and quality of data to drive systems forward? What does that look like in terms of thinking outside the box so that we're not paying practitioners for visits, but we're actually paying for quality of care and we're monitoring and measuring the quality of that care? So I also have to disclose to you that I am on a couple of boards for Eli Lilly, developing different, basically antibodies to myostatin, which have nothing to do with the ethics that we're talking about other than sort of the experiences I've had in running multi-center international trials, and Scholar Rock, who are a junior company developing some of these molecules, but we do have to disclose that for ethical purposes in the first couple slides. So lately I've been feeling ethical. Can you prescribe something for that? And I think that's one of the challenges that we've there are conversations we don't necessarily want to have, and I think we really need to have them in this day and age with data as readily available as it is in Twitter, on Facebook, and other mediums, and how do we manage that better, and how do we actually capitalize on the benefits for healthcare? So pride in our Canadian healthcare system, I'm not telling you anything you don't know. If you speak in the States, they all say, you have a wonderful integrated healthcare system. It's national. Everybody gets healthcare. It's all paid for. Your access is a little slow, we hear, but you have a great system. Well, that used to be fairly true. But today, in 1990, if you looked at the OECD reports, Canada was number one in terms of healthcare delivery and quality of healthcare. The challenge we face today is in 2014, and I suspect it'll change and will be at the bottom of the list. Canada ranked 10th out of 11 countries overall, barely ahead of the United States. They have accountable care structures in place now that I suspect the next report, we're going to be 11th out of 11. And that's a problem given our pride in our national healthcare system. And part of it is the lack of integration. When you ask a patient to go to a board and draw what the healthcare system looks like, they draw a spaghetti map. And they have no idea how to navigate that healthcare system. And we think we've got coverage, access, and everything works well. The challenge we have is people say, well, our population's going up, so the costs are going up. Well, our population went up 1.5-fold, and at the same time, our expenses went up 3.5-fold. So we're not getting better health care. And even if you look at the provinces that put more money, Newfoundland's first, Alberta's second, into health care, we have modest outcomes at best. So we don't have a sustainable system. How do we bend the cost curve? Everybody who's looked at this says you have to move out of acute care hospitals. We spend 97% of our healthcare dollars in acute care hospitals. And you have to move to primary and secondary care. We have to eliminate inappropriate care. Inappropriate waits as you try to navigate through that system is absolutely crucial. So how are we going to do that? We have to look at not making diseases an epidemic, but actually making health an epidemic the way they do in some of the Scandinavian countries to bend that cost curve. I look back, I'm not an ethicist, and I thought, okay, I'll turn to the bioethicists and say, what did they consider? In 2005, they brought 12 bioethicists together and said, what are the challenges from an ethics standpoint that Canada's healthcare system is going to face in the next generation? And basically, they went through a modified Delphi process and came out with this table. And they ranked the top 10 issues. Number one is disagreement between patients and families and healthcare professionals about treatment decisions. Number two is wait lists. 3 is access to needed health resources for the aged, chronically ill, and mentally ill. And 4th is shortage of family physicians or primary care teams. In this country, we don't have a model for actually funding teams to work together. We fund people to see individuals, to see patients for individual visits. We don't pay them based on quality, and we don't pay the team to come together. If we don't pay teams to function as teams, they won't work as teams. Our wait lists, despite federal funding in 5 priority areas, one of which was bone and joint health, our wait lists are actually going up. We had a tremendous impact, brought wait lists down, and now they're starting to go back up. If I look at rehabilitation and what we have to offer in 3 of these 4 priority areas, it's huge. And yet, we don't manage wait lists. If I said to you, what's the wait list to get into rehabilitation across this country, as the president of the Canadian Physiotherapy Association, I have no idea. We delisted healthcare services such as physiotherapy, occupational therapy, speech language. They moved where a decade ago 80% of those healthcare practitioners were in the public system. They've moved into the private system. So we're seeing about 40% to 50% if you're lucky in public and 50% in private. And they can't communicate with each other, and that's a problem. Do we have a 2-tiered healthcare system? You're seeing this in the papers now, and they're saying Quebec is different than the rest of the provinces. It's not a Quebec and the rest of the provinces issue. We actually have 2-tiered healthcare. Those of you in rehabilitation well know that many patients have to pay out of their own pocket for treatment. And I'll argue later that the treatments that we actually endorse are much more aggressive surgical treatments when conservative options are equally as beneficial for the individuals, but they're not paid for under the public health system. So what's the patient going to opt for? So the shift from the public to the private sector is something we need to think about. A couple points I want to raise with CIHI collects data on acute healthcare systems in hospitals. So most of the data that they collect is only about acute care and not about private and what goes on in the community. But remember, I said to bend the cost care curve, we've got to move into the community with no resources to integrate the care there. We also have to think about key performance indicators that are fed up to administrators and policymakers about the healthcare system. Don't actually funnel down. We also need clinical outcome measures to make individual patients' decisions with them to inform the healthcare. We need both levels. So we need structures in an aggregate format for key performance indicators to be developed in partnership with patients, stakeholders, and clinicians, but we also need the clinical outcome measures fed back to the front line, and I'll give you an example of the benefits of doing that. So how do we build this integrated healthcare data system? I'm arguing that we really need a private and a public interface, and that we need secondary data analytics, and I'll describe what that is, in order to transform our healthcare system. And I think that might be the role for the federal health minister, to look at a federated model for how we share data, not just within provinces, but across provinces. Sharing data saves lives. We know that time and time again. You can have surgery in the hospital and go to a private rehabilitation practice outside the hospital, and there's no sharing of data. They have no idea what was done to you in acute care setting. And 50% of our provincial dollars are spent on healthcare. We do a better job tracking our roads and infrastructure, not health, than we do actually about health. We need real-time data that will allow us to integrate systems that not only share amongst the different practitioners, but actually allow us to evaluate and move the system forward to reward quality. The challenge we have, if I take an individual with low back pain, it's an area we're tackling here in the province now, and they walk into a healthcare provider. They may walk into their family physician in a PCN. They may go and see a physiotherapist. They may go to a chiropractor. They may go to a pharmacist, and they may be referred to a specialist. Some individuals on a wait list to see specialists have actually been on 5 or 6 specialist wait lists that they don't even know they're on before they're actually ever seen, which might be 2 to 3 years down the road. Now, these patients, when you ask them, and Eric Meslin talked about this this morning, 80% of them assume we're sharing their medical record. And we are not sharing at all. In fact, when I met with the PCN and said, if you have a patient who walks in with low back pain, do you send them for physiotherapy? Do you send them for chiropractic? Yes, all the time for an assessment. How do you communicate with them? And you know what they told me? I write it on a piece of paper, I hand it to the patient, and they act as the carrier pigeon, hopefully to go back and forth between the professionals. In this day and age, when you have Twitter, you have cell phones, everybody's attached, we can't communicate to better care for patients. So that's a priority area for patient care. Now, how do we incent good primary care data collection? Because that's what the clinicians care about. The quality of the data will be there if it improves patient care. And if we can collect it that way, where it's identifiable and you access the charts in order to care for a patient, in the public-private sector, you're all regulated health professionals, share that information. And then in an aggregate form, we want to collect that to look at what we'll call secondary data use in an aggregate form that informs, in a de-identified manner, better performance of the healthcare system. To de-identify that data, there's software out there called privacy analytics software. You can superimpose that to ensure privacy better than the privacy we actually have now in writing things on pieces of paper and asking patients to carry it back and forth. What about access to net care? We have physiotherapists who are rostered in this province to order an x-ray. You can order an x-ray for a patient who comes to see you with low back pain in the private sector. You can't actually access net care to ever see the results of that x-ray. You have to write to a family physician and say, can you please send the results over? So it's a very inefficient system of waiting. The other issue is, most people in the province don't know that, in Alberta, physicians are custodians of the data, the medical record. Physiotherapists and other healthcare professionals aren't. And that has implications in terms of what you collect and how that data is shared. And there's ongoing discussions about how we change that legislation. If we're looking at improving patient care for quality assurance purposes, that's under privacy impact assessment. And it needs to be done in a very thoughtful way. When we can't get through that and figure out how to do it, typically as researchers, we go over and say, let's get research ethics approval to look at secondary data use so that we can inform and improve the system. There has to be a better integration, and sometimes there's gray areas in between those two. I think the best graphic I've ever seen is from Dale Saunders, who was recruited to help AIHS and AHS to look at data. He was with NASA, he also developed Intermountain Health that are an exemplar in terms of sharing data and integrated health records. And he said, many people hide behind the argument technology is not there. If you fly the Dreamliner for approximately 6 hours, you collect 500 gigabytes of data. The average individual, this is American data, but applies to Canada too, the average individual in a year would have 100 megabytes of data on their health record. That's like 3 songs on an MP3 player. So technology is not the limiting factor here. We want to form partnerships that allow us to collect individual data, put that data into a hub, that primary care, you can access the data to care for a patient, and then in an aggregate form with privacy analytics software, you can also share it for research purposes de-identified. Now, what are the challenges in doing that? In my mind, there's 2 huge challenges. One is the governance structure for how you share that. And most people say it can't be done. Do you know in this province we have expertise that they have Suncor, Shell, Sunoco, and local providers digging for oil that actually share one common data set compared to the 180 some odd different data sets that we have. So we need one patient, one record, one truth so that we can actually have a better governance structure, and that's crucial in setting up these systems. The other thing that's crucial is that governance group have to be firewalled from the data quality group that determines what do we need to measure that goes into the system. We can do this in this province for land titles. That's equally as private to some as their healthcare records. To some people, it's even more private. The data architecture is there. We've done it in this province. And what we'd like to do is put health data on top of environmental data. And what you see here is the layers that are in for your land titles, for your home, for the roads, for oil, for every tree in this province. in geospatial data. If we can do that with healthcare, now we can marry how far are people actually traveling for their healthcare, what is the integration between your environment and your health, which we know the sociodemographics of that is a huge impact. And those are the systems that we have an opportunity to build here if we can put aside what the barriers are that are often more perceived than actual. Secondary data, what is that really? It's data that was collected for research purposes that is then archived that other people can now come and access that data to do secondary analysis for quality assurance or for other research purposes. What we need to move to is that we're not just collecting data for research purposes that goes into secondary data use, but we're actually collecting it for primary care. And that every patient in this province is a partner in collecting their own data to better inform the analytics we do and build the system that doesn't look like that spaghetti map that patients draw for us. Sharing of data saves lives. The impetus for this has been really around the fact that primary data collection is extremely expensive. In fact, funders, AIHS included, will raise the issue of why do you want to create another data structure? Every researcher who applies for a project in some form collects data. And then we're mandated after 5 years, 7 years, with drug companies it's 12 or 15 years, to keep the data, to store it, and then never share it with anyone unless asked under legislation, and then destroy that data. So we put most costly systems in place to then destroy it and never use the data. Technology has changed that allows us to collect and to share in a very timely way for secondary data analysis. Now, there are risks in doing that, and I'll give you a couple examples in a minute. So previously, where we would have destroyed data at the end of a project, we're asking now to keep and share and better inform each other from analysis of that data. That's a major shift ethically in how we look at what is collected and how we garner consent and look at privacy to make sure we store securely and share that information. That is no longer a nice thing to do. That's the default position that is expected of you as a researcher in Canada today and other countries. Some people actually argue that if public dollars go towards funding research, towards funding quality assurance projects, that data must be shared with the public, not just with other researchers. And access and the return on the investment is seen to be so high, particularly for healthcare data, that now individuals are saying it's not only nice to do, it's necessary and a moral imperative that we do that. Open access now to secondary data is becoming more and more something that's moved to the forefront, and there are mandates to not just provide the data, but to do it in a timely and an efficient manner, where researchers saying, well, do I have the infrastructure really to meet these demands? And those are the conversations that we need to have. There's lots of examples now about how that's done. The cost is no longer a barrier. It's more expensive to continuously collect data in primary care and never to share it. The technological advances, as I've shown you, are such that data is cheap to collect and to store, but we need to be thoughtful about the privacy around that. This is creating ethical and legal issues, and in between those issues are the gray areas. So we need to think about informed consent. What does that mean if you're collecting data that's going to be kept in perpetuity? What about confidentiality and anonymity? How secure are these databases? Where are they located? How do we protect the data? What's the use beyond the original purpose? And everybody automatically goes to the tobacco industry. There were studies done years ago that looked at what is the youth and what are younger attitudes towards smoking. And people filled out these surveys. Philip Morris then, as a tobacco company, said, wouldn't that be great data? So under the privacy legislation, they came forward and said, you have to share this data, and they were forced to share the data so that the tobacco companies could then use the data, analyze it, and better appeal to the youth to take up smoking. So we do need to be cognizant of how it may be used for other purposes, but it doesn't mean that it's a barrier not to be able to have these conversations and share the data and do that. Who owns the data? Especially in situations where physiotherapists, chiropractors, and regulated health professionals are sharing data that they're actually not custodians of. And I'm sitting on a panel in the States where we're sharing across about 47 states integrated physiotherapy outcome measures, and there are 22 different registries federally in the states that are integrating data across the United States from several states that is healthcare data. We can do a better job of that in Canada, but we're barely scratching the surface within the province, never mind between provinces. So we need new policies, we need data protection, we need freedom of information and privacy legislation, but it shouldn't be the barrier to getting this done if we truly want a healthcare system that works for us. What we see is the progress in data sharing is clinically people are already there and they're running, and we have the early adopters who have been at this for quite a while. That's the new millennial generation. Then we have the technology that's just catching up to that point. And we often look to the legislation and say, okay, can I do this? We look to the ethics board. Should I do this? Can I do this? What are the barriers? What we have to accept is this is new territory. This is new grounds. And often the regulatory arena only catches up, and there's a delay to catch up to what's already being done. But if we partner together, I think in this province we have a unique opportunity to have exponential growth in sharing of this data that better services every Albertan and the healthcare that they need. This says medical ethics, and then the commentary is if there's a Privacy Act, slap it over the top and that'll get us off the heat for a while. There are many gray areas and ethical considerations in between ethics and legal requirements. Just because they're gray areas doesn't mean we need to shy away from them. There's lots of governance, there's lots of examples to use about how we can do a better job. And you often see, oh, I'm sorry, but it's a privacy issue, we can't go there. Well, you know, that's an ethics issue. No, that's between ethics and privacy. Don't really have the legislation. Sorry, come back tomorrow. Come back next year. We have to get over that and have a coalition of the willing. All of the elements are there to be able to do this. The patients are asking for it, the public's asking for it, and it's time we started to collaborate to do that. What I'm seeing today is people weigh between ethics and legal issues. The ethical issues to me is, can you identify the values, what ought to be? On the legal side of things, it's the expression of those values in rules and regulations. And more what I'm seeing is individuals and institutions saying, well, it's not quite a legal issue, it's not quite an ethical issue, not sure where to go. And so you see a whole thing coming up now for institutions of risk management assessment. So whole teams now in banking industries, in healthcare, our association at CPA is looking at how do we manage the potential risk and reduce our liability associated with that for gray areas that fall in between. And I think we need to pay a lot more attention to using and bringing ethics and legal issues together. Data-driven decisions. Deming said many years ago, in God we trust, all others bring data. If we're going to drive PDSA, and that's plan, do, study, act, cycles of improvement, we need to collect and measure the data. Here's an example of what we've done in the front lines. Alberta has, you're familiar with this, 6 dimensions of quality. We brought stakeholders, patients, clinicians together and said, what are the key performance indicators? How do we measure that? And we implemented a system in bone and joint health to measure that across the province for total joint arthroplasty. The upshot of that was we learned a lot about the metrics, about what we were delivering and whether or not we were improving care. We took, and this is really important to understand, a balanced scorecard approach that comes from business. And at arm's length from Alberta Health and Alberta Health System, CyFrank had the foresight to set up Alberta Bone and Joint Health Institute, which is a not-for-profit organization which collects data on patients, everybody going through a joint replacement in this province. patient-reported outcomes, because believe it or not, giving patients inside Alberta Health Services access to their own data is the most difficult part of this equation. We're collecting data that actually goes to a server at U of A and then down to Alberta Bone and Joint Health Institute, so they can merge it with data from Alberta Health Services for your care in hospital and Alberta Health in terms of costs associated with having a joint arthroplasty. We take that information and we give it back to the front line. Remember, I talked before about not just key performance indicators improving the system, but sharing it with frontline. Frontline teams come together about every 6 months to a year and look at their balanced scorecard. They start where they set the metrics. A 3 is the bottom level. Once a 3 consistently improves to an 8, the 8 becomes the new 3. The whole system is designed to improve the minimum standard. It is purposefully not handed over to a college or a regulatory arena to identify outliers and go after anyone. That's not the purpose. It's a systems approach to improve the whole system. Not only do we do that for institutions, but we actually do that for individual practitioners and individual surgeons in the province. As soon as we present the data and the variability, we got a call from the College of Physicians and Surgeons, said, can we talk to you about, can we see this data? Had the meeting and said, thank you for your interest. What you can do is share with other physicians and other practitioners in the province how this model works and the benefit, but not try to intervene so that you would identify outliers. Maybe the outliers are actually the best clinicians, and we have to put in place a system that allows each individual their own feedback to improve. And that's what we need to do between the private and the public sector. The data analysis, therefore, has to be at arm's length from the healthcare system, from the regulatory arena, in a peer-reviewed group that allows individuals to look at their own data, to set their own benchmarks, and continuously improve. The process of getting through ethics is not the same as ethical research practice. We heard this morning from Eric that it is crucial. There are always gray areas. I could write an ethics approval that I know will get through ethics without telling 100% of the truth. It's not untruthful, but it's framing it in a certain way that they will give me permission to do it. For me to then say, look, now I have permission, ethics has approved this, ergo it's ethical for me to behave this way, is totally inappropriate. There are those gray areas where it's incumbent on us as clinicians, as researchers, and as patients to be as ethical in that process as we can. We have to be above the law and above ethics as we broach into new gray areas. I want to go back to that example of the balanced scorecard approach, because when we tracked improvement in the system over time, until we actually implemented the balanced scorecard, we didn't see significant benefits to the healthcare system. In this province, there are now 73% more total joint arthroplasty surgeries done, with only 5% more acute care bed days. It's huge savings, millions of dollars of savings to the system. When we measured it, it was largely due to rehabilitation. We can do more hips and knees because we get patients out of bed on day 0 or day 1. Had we not measured that, had we only measured wait times, we wouldn't have that information to know really where to target the healthcare system. The other important point here is the reduced costs. So now that we've saved this money, how do we reinvest in the front line to build systems to better integrate the data so that when you leave hospital after a joint replacement, you can actually communicate with your provider in the private sector? The last point I want to make, as successful as we've been in this province in joint arthroplasty, and health ministers, when Cy presented to them from across the country, thought we had done a fantastic job. Have we really? Because you can get in to have your joint replaced faster than you could before. Is that really appropriate? So many patients now come saying, if I need a joint replacement, I know that you've streamlined the system. But maybe I want to use primary or secondary approaches, conservative management for my hip or knee osteoarthritis. How do I access the system? And our answer is, if you want to pay out of your own pocket, you can do that and access healthcare. But if you want to go to the public system, well, now we're going to replace your joint. What we're seeing in this province, in Canada and the United States, is a reduction from mid-70s to the high 50s, patients younger and younger are coming in for joint replacement surgery. So we are biasing the treatment options. Here it says try to focus less on a cure and more on a treatment that you can afford. And Canada has to stop dividing the two and say what's really necessary for us to cover in order for us, and what do we need to measure in order for us to make those decisions. CIHI's data can't just be in acute care hospitals. It now must focus on metrics in the community and integrated care.
Thank you.